how long has canaloplasty been around? Canaloplasty is a form of non-penetrating glaucoma surgery. Non-penetrating just means that the wall of the eye is not cut all the way through. In theory, and often in practice, this means that a bleb and its associated risks are avoided. Non-penetrating glaucoma surgery was developed specifically to avoid the high risks of penetrating surgeries. One of the first attempts at creating a successful non-penetrating glaucoma surgery was reported by Dr. Cairns in 1968. Dr. Cairns wished to avoid the complications associated with penetrating surgery. Additionally, he felt that it was unnecessary and unphysiologic to create a bypass to eliminate the activity, therefore, of the collector channels from the Canal of Schlemm. In other words, he wished to maintain as much of the eye's natural drainage function as possible. Because it was felt that the main restriction to fluid exiting the eye was located at the trabecular meshwork, Dr. Cairns developed a glaucoma surgery which was intended to cut out a portion of the trabecular meshwork. Removing a section of the trabecular meshwork created an opening in the Canal of Schlemm through which aqueous could pass unobstructed into the collector channel system and out the eye. He specifically wished to restore the integrity of the wall of the eye, the sclera, by suturing it firmly back into place, the intention being to secure a watertight union. What did Dr. Cairns call this non-penetrating glaucoma surgery? Because the main purpose of the glaucoma surgery was to create an opening in the Canal of Schlemm, the surgery could easily have been called canalostomy. However, because his technique involved removing a short length of the Canal of Schlemm with its trabecular adnexa, thus leaving two cut ends opening directly into the aqueous humor with no trabecular tissue remaining as a barrier at that point, he chose instead to call this glaucoma surgery trabeculectomy, as a section of the trabecular meshwork was removed. So what happened? Despite his best attempt, of the 17 cases first reported in 1968, in 6 cases a bleb appeared. These may be regarded as failures in that the effect intended was not produced. Additionally, it turned out that without a method of keeping the Canal of Schlemm open, it eventually scarred down. It was soon noted that the surgical failures that developed blebs were the patients whose intraocular pressures were best controlled after surgery. These failed attempts at creating a non-penetrating glaucoma surgery were, however, experiencing far fewer complications than patients who had received the other penetrating surgeries of the day. So in essence, the most common glaucoma surgery performed today is a direct result of a failed attempt to create a non-penetrating glaucoma surgery. Now, Dr. Cairns may not have been successful in his attempt to create a truly non-penetrating glaucoma surgery, but the quest for a safer, effective surgical method of controlling glaucoma has continued. One of the modern pioneers of non-penetrating glaucoma surgery is Dr. Robert Stegman of South Africa. 2 decades ago, he conceived of the idea of not only creating a canalostomy, but of dilating it with a surgical gel called a viscoelastic. He called this procedure viscocanalostomy. It was Dr. Stegman's hope that by dilating the canal, he could overcome the problem of stenosis, that's scarring down, of the opening that led to the failure of Dr. Cairns' original attempts at non-penetrating glaucoma surgery. Dr. Stegman's surgery did successfully lower intraocular pressure, though not as much as trabeculectomy. An added benefit was that it reduced risks compared to penetrating surgeries such as trabeculectomy. Fast forward a decade later, Dr. Stegman improved upon the success of viscocanalostomy by using a microcatheter to thread a suture around the canal. He then tightened the suture to keep the canal open in a manner similar to how cardiac stents keep blood vessels open during angioplasty. He called this procedure canaloplasty. In 2008, the FDA approved canaloplasty for use in the United States. So, how long has canaloplasty been around? Since 2008? Or could you argue that its origins go back as far as 1968, almost 50 years ago? Is it a fad, as many surgeons who do not perform canaloplasty suggest it is? Or are penetrating surgeries, such as trabeculectomy, the real fad that will someday be replaced by safer, effective, non-penetrating glaucoma surgeries? You be the judge.